For patients with locally advanced non-metastatic esophageal and stomach cancer, the multidisciplinary approach between members of the pathology, surgery, radiation, oncology, radiology, and medicine, medical oncology team members is crucial. The first decision tree, fork is this disease curable? And a careful review of the radiology and pathology is very important to determine the treatment plan. For patients with localized disease that presents with symptoms and radiographically visible tumor, in the majority of the cases, surgery alone is insufficient to cure this patient. And therefore, medical oncologist really becomes the center of the coordinator of the team to help improve chances of cure and really get this patient through an operation, ultimately with the help of all the team members that will cure them. Because in patients that undergo surgery first, they may undergo suboptimal resection that is not R0, which means it's not a complete resection, and then you really wasted an opportunity potentially to cure this patient. Because after the surgery, the patients are usually nutritionally compromised and quite frail and are no longer able to receive chemotherapy or chemoradiation, treatments that could have augmented their response and success of the surgery from the beginning. And that's why it's very important to sit down together, take even something as 15 to 20 minutes. It doesn't take very long, but look at the images together and figure out what's the plan here, as opposed to trying to piecemeal it together later on. For metastatic disease, again, the chemotherapy is the most important treatment, and for majority of the patients, the disease becomes a chronic illness. In these situations, radiation and surgery become a way to help improve their quality of life or treat or palliate some of the symptoms. But again, chemotherapy is important, but increasingly with the use of immunotherapy and other targeted agents, we've used radiation therapy, focal ablations to help augment the immune response to the tumor with systemic therapy. But again, this is more of a research tool at the moment.
So when we evaluate patients with gastric and gastroesophageal junction cancers, we do try to take a multidisciplinary approach, because we recognize that in the absence of metastatic disease, those patients will need a combination of chemotherapy, radiation therapy very often, which is provided by the radiation oncologist, and sometimes surgery if it's appropriate. So it is a disease which is well served by a multidisciplinary approach. And there's many mechanisms to do that, obviously, but one of the better ways is usually to discuss these patients at a tumor board setting where all of the disciplines are represented. In patients who do not have metastatic disease that have treatment for curative intent, the goal would be to involve, in some way, shape, or form, all of those modalities in the treatment of the patient.
Patients with locally advanced stomach or GE junction cancer can be cured. The challenge is, how do you do that, and what's the best order in which to do the treatments? Combinations of chemotherapy, radiation, surgery, and mixing and matching of all of those may be the standards. Certainly in Europe, the standard is chemotherapy followed by surgery. In the US, it might be more standard would be surgery followed by chemotherapy and radiation, and then there are variations on that theme. But the goal is to cure the disease. You achieve that infrequently, but you do achieve it occasionally. Again, in Asia, you might achieve it more commonly, because biologically we think gastric cancer is different in Asia than in the West. But here, again, the combination therapy, the goal is to cure the disease. It probably happens in 15 to 20% of patients.
So the optimal chemotherapy regimen for adjuvant and neoadjuvant in gastric and GEJ cancers is quite controversial. It's very different depending on where you treat patients in the United States versus Europe versus Asia. I think generally speaking, though, most of the data it supports neoadjuvant use for patients that are at least T3N0 or above, which are patients that have the suggestion that they may not be fully resectable. So they're not fully resectable, which is the majority of patients with gastric and GEJ. Those patients often now, the data supports neoadjuvant treatment in the form of gastric cancer, usually neoadjuvant chemotherapy alone, in newer regimens such as the FLOT regimen, which has shown improved survival outcomes compared to the older regimens like ECF. And in the case of GE junction adenocarcinoma, where there's a role for radiation, most of the data would support neoadjuvant chemoradiation with the so-called cross regimen, which is fractionated radiation along with carboplatin and Taxol given weekly. So those are some of the main elements. I think if you have a situation where it's not given neoadjuvantly and then is found to meet criteria for adjuvant therapy, there's support to do that as well, obviously, after surgery. But I think if we're looking at the trend of the last 10, 15 years in these diseases, it's been to move more of the treatment to neoadjuvant as opposed to adjuvant. So the role of radiation and chemoradiation in neoadjuvant gastroesophageal junction is, I think, well demonstrated in regimens like the cross regimen, where the role of chemoradiation is important because some of the tumor may involve the gastroesophageal junction. However, in body of the stomach tumors like gastric cancer, the role of radiation is much more controversial. And recent studies have suggested, such as the CRITIC study, that there may not be much benefit to giving adjuvant radiation in some of those patients. So we're waiting for more studies that are ongoing now, such as Top Gear and ARTIST-2, that will further clarify the role of radiation in gastric cancer. But at this point in time, the only data we have for adjuvant gastric cancer radiation is relatively old data from the intergroup study, where there still was a role of chemoradiation in the adjuvant setting, but is much more controversial as opposed to GEJ.